Hello, I'm Jamie Smith, a cancer control specialist with the Kentucky Cancer Program. Welcome to today's show. Today I have two guests from Lourdes Hospice who are here to discuss the hospice program in our area. If you would just take a few minutes to introduce yourself.
My name is Jim Long. I'm an internal medicine physician and I'm one of the co-directors of hospice.
I'm Reta Lewis. I'm the patient care coordinator, one of the patient care coordinators for Team 2 in Illinois in hospice.
Okay. What exactly does a patient care coordinator do?
Helps to coordinate the clinical staff for the care that's provided out in the homes, nursing homes, and in the field, and works together between the team that's in the field and management, and keeps everybody on the road with the tools they need to get our job done.
Great. I guess if we could just take a few minutes to tell everybody exactly what hospice is, what all it entails.
Well, hospice in general serves to provide care to people that have reached a point in their illness where they're not getting acute care. We sort of see it as another level of care, trying to enhance their life whatever time they have left. We focus a lot on support of the family. Pain control is a big part of what we do. It's just sort of a global care of the patient as they reach a point where acute interventions aren't going to be done, but they still need care to maintain their quality of life.
Okay. If someone wants to know whether they're eligible for hospice, what are the requirements that would...
Anyone can call our office for information about hospice, and we encourage the community to learn about it before maybe you need that service. But anyone can call for information to actually be able to physically go out and see a patient and assess them. We have to have an order from an attending physician to go assess them for care.
All right. I think you said something important too, just for the community to kind of know about hospice. Mm-hmm. Some people don't know about it. And then also, I know that you all look for volunteers, and what a better way to learn about hospice than becoming a volunteer.
Right.
So they could also do that to learn different
Sure.
aspects of it as well.
We have a great volunteer program. It's a lot of people that have been touched by hospice, maybe had family members in hospice care. It provides such a great service to families. They go out and will run errands, provide respite care for someone to get out of the home for a short time. Some work in our office and are support to us, but yeah, if you're interested in volunteering for your community, it'd be a great service.
That's wonderful, and people are always looking for volunteer opportunities. So, one thing that we may want to talk about just briefly are the number of patients in the community that would actually qualify for hospice but aren't taking advantage of it. Do you know kind of the comparison for numbers with that?
I don't have any statistics, but my perception is that hospice is underutilized. Mm-hmm. Certainly, in the nursing home population, I think there's a significant underutilization. Many times people are referred to hospice sort of late in their illness, and we feel that the earlier that they're engaged in hospice, it's better for the family, it's better for the patient, allows us to develop rapport with the family, which I think is a real important service that the hospice nurses and volunteers and other providers can give them. My gut feeling as an internist, I know until I became involved with hospice, I probably didn't refer as early as I should have. Have a lot different insight into it now than what I had before. But I think in general we tend to refer a little bit too late in the game. Now there are certain situations, someone who has cancer, obviously they're going to be treated aggressively up to a certain point. When that cancer treatment is failing, the patient and his family may opt to forego treatment, and that's when hospice gets involved. We're not really involved in patients that are getting aggressive treatment.
Okay.
But so I think there are other areas though that I think where we could be more aggressive. People have end-stage heart failure. People have bad lung disease. We do take care of more and more people who have end-stage renal disease that have been on dialysis, and for whatever reason they've opted not to do dialysis. But as far as numbers, I think we probably could definitely take care of a larger volume.
Right.
And I think it's probably underutilized in general, though I think that's getting better. I think physicians are getting more tuned into that, and I think as the population ages, people become more aware of more quality of life issues, especially at the end of life. I think we'll see more of an upturn with that. But at the present time, I think we could certainly handle more of these folks, and we'd like to see them earlier in the course of their disease process.
Right. Well, and hopefully today maybe some people may spark their interest and call and find out some more information about maybe the entry time. So we talked about it's being underutilized, but you talked about when to actually take them into the hospice. So is there a certain time in care, or is that something that a doctor and a patient need to decide together? Or?
I think usually that's sort of the people that are involved in the patient's care. The patient, of course, is primary determinant of when that starts, but in conjunction with the advice of their physicians. Family has a big role to play in there, because many times they're intimately involved in the care of the patient who's in hospice with the support of hospice. Timing-wise, and as far as making that decision, that decision can be made at any point, and sometimes it's hard, because it's hard to determine when are you going to walk away from that treatment. I mean, it's hard for the doctors as a physician. I know for me it's hard to tell someone, we've done everything we can do, we need to move into a different phase of treatment. And everyone sort of has their own threshold, individuals as patients as well as physicians. So there's wide variation, I guess.
So a patient, if they're in the hospital or if they're at home and receiving care, but maybe even through home health first and then entering into hospice, what can a person really expect when hospice comes in to kind of tell them about the program? What should they anticipate?
And I wanted to touch on something too that Dr. Long had said. I was so glad that he mentioned other diagnosis. There is still, Jamie, I guess the myth out there that hospice is only for cancer patients, and any life-limiting illness, any disease process, anything, you can qualify for end-of-life care. So I think a lot of people still don't know that. Now back to your question. What can somebody expect? When you get admitted to hospice, you kind of get the whole ball of wax, which is the whole entire interdisciplinary team, starting first with the patient and the family. That's the main unit of care. We have great medical directors who help us and support us. We include their attending physician. They will have a RN case manager who will help manage their care, nurse aides available to go into wherever they are, home, nursing home, whatever level, and provide personal care, social workers to help with any resources or social issues that they need, and then our chaplains address spiritual care, the volunteers we spoke about earlier, our bereavement staff that get involved sometimes early before the death to be have their foot in the door and have a rapport with the families before. But it's a great team of people. It's a lot of collaboration between the team, and with all of us having our own area of expertise, it provides the best quality that we can provide to people.
I've only been doing this 6 months, and I've been really impressed at the dedication of the people that work there. I get some calls from them periodically, and they'll be at someone's house at 2 in the morning managing some pain issue or something that's happened that patient needs, and the staff from top to bottom has been very impressive. And I think that that's one of the things, I guess, from my standpoint, I'd like to see people utilize it more, because I think physicians and families and patients don't always recognize what they could get from the program. And I think that we really have a lot to offer, and the dedication of those people and the way that they manage crises and do things has been very impressive from my standpoint as a physician.
Rita, you just said something interesting, and whenever you were talking, you said not just in the home, but you said a nursing home. So a patient doesn't necessarily have to be at home to receive hospice. No,
we'll see people wherever they are. If they live in their car, I presume we would see them there. But primarily our care is provided in the home. We also have a nursing home census. And if they're requiring an inpatient level of care in an acute hospital, and at that point, then we have admissions and see people in the hospital as well.
Okay. One thing that maybe people think about with hospice, we've talked about it already when you talk about death, but not necessarily that is the outcome of hospice. a patient, is it true that a patient may recover and be able to go
Sure.
back and?
Certainly. It's a happy day in hospice when we get to discharge somebody.
Yeah.
Their condition might stabilize, they may get into a remission, no longer be declining, and we'll discharge them from our service. They can always come back into our program. The benefit's unlimited.
Okay. Well, that's good to know then too. So one thing people may be out there asking, you talked about being in hospice then going out, but you said it was continuous coverage. But who actually pays for hospice, for like insurance wise?
Hospice is a benefit under Medicare.
Okay.
It's also a benefit under their Medicaid. Private insurance, most private insurances cover hospice. VA has hospice benefit. And then there are some people who don't have a resource, but we're going to provide care if they qualify regardless of their ability to pay, but then hopefully get our resource people in there and find some resources for them to help them or secure some kind of payment.
Okay, that's good to know too. Whenever patients are actually in the hospice program, then you've talked about this huge team that you all work with. So who actually goes into the home then to take care of this patient? Is all of them, the doctor actually going to the home as well?
We do have one physician who can help us with home visits if that's required, and maybe communicate that back to some of the other medical directors. The nurses are in the home. How many times depends on need. You may see a patient once a week, or you may be there every day that week if they're having issues. The nurse aides are in the home, the chaplains, the social workers, the volunteers. And like I said earlier, our bereavement coordinator even gets involved sometimes early, but we go out to where they are, into their environment for care.
So then I assume too, you talked about sometimes at 2 in the morning receiving a phone call, then that staff is available.
We have nurses 24/7. There will always be nursing care available to them, and what's great about having good directors is you're not afraid to call at 2 o'clock in the morning. People can't choose when they die, and they don't know when they're going to get in a crisis, but we have a evening and weekend shift that covers evening and weekends, and they're the ones oftentimes that get into trouble and have to call for some help during the middle of the night.
Right.
But there's always that available to you.
Okay. Well, I just think that's great to know that someone's there, and yet they're still in the comfort of their own home or wherever that they live. One thing that we may want to talk about too is hospice may be able to supply some equipment that maybe is at a hospital that can actually go into the homes. You want to talk briefly about how that works? I'm sure there's probably a physician's order involved in that.
Well, for people in hospice, home care, other types of things, physicians can order things like hospital beds, various types of things that they may need for comfort. That's true in a variety of settings. Many times the hospice nurses or the people that are going out to evaluate will let us know that this patient needs a hospital bed for comfort, they need a walker, or they need a wheelchair, whatever the oxygen, a pain pump perhaps, something to get IV pain medications. So those things can all be provided.
Okay.
And from the standpoint of how that's done, it's just a matter of if you can show that they have the need from a medical standpoint. There's certain diagnoses you have to have sometimes and certain forms that have to be done, but we take care of that type of thing.
Great.
And so it's really pretty easy to get them if something that they need. That's not really a hindrance.
Okay.
Under the umbrella, I guess, of hospice, we provide any medical equipment, like you said, to make care easier and more safe at home. We can pretty much provide anything they need as far as equipment. Also then providing medications for them related to their diagnosis to keep them comfortable. If they need supplies, if they need any kind of supply for a wound or briefs or anything like that, those are also provided through the hospice program.
Okay.
Yeah.
Well, we've certainly talked about a lot. We're going to take a short break and come back and discuss all this a little bit more. Okay?
Thanks.
Welcome back. We just briefly discussed some of the equipment that patients may receive while they're in the home. Also, we were just briefly talking about medications and other supplies. So let's talk a little bit more about medication management, pain management, things like that for the patient while they're in hospice.
Well, the medication management part of this is a really big thing, of course, because many of these people have chronic pain or other conditions we have to manage. We have a lot of resources. The pharmacists at the hospital help us with various types of things. We can get a pain medication for someone at any hour, virtually, if they need it. Different types of modalities, pain pumps I alluded to earlier, patches, different types of oral pain medicine, antidepressants, pain for nerve pain, breathing type medications. There's just the whole gamut of things are available. The nurses and the team utilize something called hospice pharmacia, and basically they're on call all the time to give us advice for converting medications. If a person's not tolerating this pain medicine and we need to make a conversion, they can make that recommendation. One of the things that surprised me was how many things you can give to someone through their skin. There are different ways that the hospice pharmacia can help us with formulating medicines, different types of things for nausea and vomiting, for confusion, that you can actually give through a cream. There's just a whole variety of things that we have available to treat people. Want to expand
Many
on that?
concentrated drops too. You know, people get eventually where they can't swallow well, and pills are hard to choke down. And besides the gels and the creams, patches, they provide some concentrated medications that we can just use like drops under the tongue if someone's not able to swallow.
That's good to know. Then whatever makes it easier for the patient,
Right.
make them comfortable.
And make it easy for the family. They're the ones who are there. You know, we're there to provide support to them, but we need to have something that they can manage that's easy for them, not distressing, to try to get, you know, a patient's medicines given and get them comfortable. And then symptom control is, like Dr. Long said, a big piece of that is the medication management, but then also to look at the spiritual, emotional, you know, those symptoms as well, and make sure that we're addressing those. We also have therapies available if they should need a therapy. Sometimes that can be a treatment to send a therapist out to help them, you know, to learn to transfer a patient, exercises they can do if they're trying to not lose all of their range of motion, and so many treatment options through many different avenues.
Do you all have a dietitian that comes in as well?
We have a resource at the hospital for a dietitian that we can consult should we need that.
Okay. I think one thing that we've talked about is also the family. It's not, you know, just the patient, it's the family that's involved in the total care aspect. And so what actually resources are available for the family as well? You've talked about social workers and things like that. What can they provide for those families and the nurses?
They can help them find resources if they need it. They could do a lot of counseling. They do a lot of teaching. Our chaplains and social workers, well, all of our staff, do a lot of teaching to the families, supporting them, just helping them with anything they need to provide the care. They are the ultimate caregiver. We've got to give them the empowerment and the tools to get that done. And then after a death, the family is supported for 13 months. We have a bereavement program that's 13 months long. They'll continue to be contacted. They get a series of books that are great. We hear people really appreciate those. There's a memorial service once a quarter where we recognize the patients that have passed and memorialize them. They're invited to support groups, bereavement groups, many things for those 13 months to help continue checking on them and follow up with them.
And where do those groups meet?
Various places in the community. We have every Monday evening a support group at the HIP building in our office, but then Leah Fonda is our bereavement coordinator, and she has gotten out into the community and has groups that meet, I think, in Arlington and different places around, and that's information is certainly available if somebody wanted to call and find out if a group is near them. We can let them know.
That's certainly probably popular now with the price of gas. People
try to
aren't
find
gonna wanna
something close to home.
travel in from the outlying counties. So, okay. Well, I think too, after a certain point in time within hospice, and you talked about the bereavement and those things that are there, it may be nice too to be able to come together with other families that have gone through that process, to be able to share experiences, and I'm sure you all probably hear stories and see that bonding that appears between those people.
Right.
So 13 months, you said, and then you talked about a memorial service. Where is that held at?
At the Lourdes Chapel.
Okay.
We have one every quarter, and they'll get invited. Any hospice family that's had a loss, they'll be invited, and then to the community as well. If there's been someone in the hospital who has passed, it's a nice service, and it's always, we get a lot out of it, and it's nice to come back together and see families and visit with them. Some of the staff always try to attend, and they may see their nurse or their nurse aide, and so that's always a special thing.
So that's not just for the past 13 months, though. That's for anybody that's ever lost a family member. I guess as you have staff retire, do they ever come back? And
Sometimes they do. We try to get staff there. It's great. We get so much more out of it than you can believe. People ask a lot of times of our staff. It's something we hear frequently in the community about. How you do that?
Right.
Why do you want to do that? End-of-life care must be hard. It's emotionally draining sometimes, but it's the most rewarding thing that I've ever done in my career, and hear my peers say that as well, is the reward is great, and we get way more back, I feel like, than we give. To be invited into people's homes, and during that time of their life, it's so difficult. To be invited in is our honor and privilege to get to serve them. So
that's wonderful. Well, Dr. Long, as a physician, if someone is out there kind of hesitant about hospice, what would you say to them to kind of alleviate those concerns?
Well, I think one of the big concerns that sometimes people have, subconsciously or consciously, is, does that mean that we're not going to what's going to happen to me as far as care? There may be a bit of a perception sometimes that you're kind of giving up on them at that point. And I think you have to emphasize to them that that's just another level of care. This is just part of the living process, and trying to keep them comfortable and trying to improve their quality of life is really what the point of this is. And I think most people, when you talk to them in those terms, they're pretty receptive to it. I think the hardest transition, again, is going from, we've been really aggressive, and I think this is hard for doctors too, we've been aggressive trying to treat this problem, and now we have to make a switch. We have to it's a mindset switch. Now we're not going to give you chemotherapy, we're not going to give you these high-powered medications for whatever the problem is. Now we're going to try to keep you comfortable, we're going to try to improve your quality of life for whatever time you have left, hopefully maybe even see you improve, maybe and sometimes be able to leave hospice. But I think most people, once they understand what it's about, are much more receptive to it. But it is a hard transition. It's hard as a physician sometimes to make that mindset switch that this person's at a point where you're not going to be able to help them in the conventional treatment way, and you need to move into a different arena. But it takes a little time and some discussion.
Do you often involve the family then too with the patient?
Yeah, it's usually family and patient, and everybody's sort of making that decision together, and it's usually not something that's made lightly. The families generally, many times they've thought about it. It's not done in a vacuum. Sometimes we've had discussions, or I have at least, I know many of my partners have, where you'll bring that up to a family member and say, if this doesn't work, we might need to move into a different phase. And sometimes you'll mention hospice. And some people just don't want to make that decision. It's a hard decision for them. And others just move right into it and accept it and go forward. But everybody's different. And every physician, how they handle it is different, and every family's different. But usually once they know what to expect, I think that's one of the reasons, I guess, why we're talking about it is once they understand what to expect, it makes it easier to make that transition. And again, I think many people don't understand or don't realize what they can get from hospice, particularly with those end-of-life issues and their family being supported and so on. So,
well, Rita, what advice would you have for a patient family that come into hospice? And Dr. Long's talked about the anxiety maybe that the doctors tried to help before they've entered into the program, but what can you all do as a caregivers, to help the patient and then to help the patient's caregivers as well?
First of all, just to promise them we're going to be there for them. They're not in this alone. It's very difficult to take on caring for somebody at home. It's a big job. But to be there for them regardless of what it is, never be afraid to call us whatever that they need, but to support them through and just walk that journey with them. It takes a lot of time to build a rapport and trust with people. So, Many times I hear, I wish we had called you guys in sooner, wished we'd have had you here sooner. So therefore, great education as we're doing today to let people know what we can do, but we're there to support them whatever they need. You know, something new comes up every day, something maybe we've never faced before. But the trust that we will see them through it and provide their needs, provide their care. You know, if something works, we're the first, or doesn't work, we're the first ones to say, well, that didn't work, let's back up and get a new plan. Let's find something that's going to work out for everybody.
And just to expand on that a little bit, we do sometimes have situations where the family's getting really tired, or they have to travel, or something else, some other crisis comes up. We'll put patients in the hospital for what we call a respite bed, where they can come for a period of days. It's not uncommon to put someone into the hospital for adjustment of their pain management when their pain's out of control or some other issues come up. Many of the patients we do get are in the hospital already, and we take over their care or assist in their care, as the case may be, to help from pain with pain issues.
Well, we've certainly learned a lot about hospice today, and the total aspect of it, from just even the thoughts of it into a care plan of care. And we want to give a number for people to call if they're interested in learning more about Lourdes Hospice. That number is 415-3636, or there is an 800 number if you're outside of Paducah. That number is 1-800-870-7460. And Rita, if you could just really quick tell us what areas hospice covers.
We cover a 13-county area, 3 in Illinois, 10 in Kentucky.
Okay.
Pretty much in the western Kentucky end
Okay.
are covered, and then the 3 in Illinois, southernmost Illinois.
All right. Well, if you'd like to learn more about hospice, again, please feel free to call those phone numbers. And then if you'd like any more information on cancer, please feel free to call the Kentucky Cancer Program at 270-442-1310. Thanks for joining us today.